Okay, so today we're going to talk about PPE. We've got a little bit of an outer space disco, outfit here. So a lot of people are designing different kinds of PPE, very colorful at that. So that always makes for a nice visual, expression. So kind of interesting. Next slide, please. So some questions that we have that related to the survey that we did, the poll. So having in place adequate measures for supply, at least for 2 weeks of PPE. I think we're a little bit better now than we were at the beginning of the pandemic. And of course, were there contingency plans? The idea here is to have you trained your staff in proper selection and donning and doffing. We're going to talk a little bit about that, and as to the need for just retraining and just reviewing that as part of a PIP that you can use to make sure that people are compliant. Just as a hint or a suggestion, that if you see people donning N95 masks, for example, and if they're touching the mask itself as opposed to the ear loops, that might be a area for a PIP for improvement and retraining. And then, so we answered all these other questions here pretty good. So I think we're all pretty familiar and are all engaged in those elements for proper PPE. So next slide, please. So this slide really tells you the gist of what happens. And so the research shows that as we talk, we produce jet-like streams that shed and produce particles. And it turns out that it only takes 30 seconds of conversation for those particles to reach 6 feet and even longer. And so there's this whole issue about containment and the volume of speech, as well as the use of P's. I don't want to say spitting, but as they call them plosives. You kind of push the words out, and those produce even more particles. And interestingly, those gator masks, where people have to pull up over their face, those create even more jet streams and can be even more dangerous. So if you see somebody walking around with one of those gator cover-ups, steer 20 feet away from them, because they're actually like jet engines spewing particles out into the air as they talk. Next slide, please.
So I just wanted to point out that there's a study that occurred a few years ago that looked at the doffing contamination. And so what they did is they went through over 400 staff members in a nursing home and they used a fluorescent lotion to monitor any type of contamination. And they found 46% of either skin or clothing got contaminated. And and then by retraining the individuals on donning and doffing, they were able to reduce that by over half. But still, just to point out that there was still contamination occurring up to 19% even after that retraining. So this is just part of the reason why, what we call in hockey, the one-timer is not good enough. We need to have several shots on goal here to really get high quality donning and doffing of our gear. Next slide, please. So we know that there's different levels of mask efficiencies, and the N95ers are the best. However, I'm just going to, a little caveat that we'll talk about again is that the CDC has discovered that the KN95 masks, whether they're from China or other sources, 60% of them are ineffective. And that just with that revelation, I'm kind of going stir crazy with that, because it turned out that University of North Dakota, that's all they ordered were KN95 masks, and I'm not too happy about that, quite honestly. The The other thing is that of the N95ers that come from 3M, 13% of the users have a inadequate fit, and if you refit them and do fit testing, about half of those then will become inadequate fit. By contrast, the next point there is that surgical masks provide 60% filtration, and those are the ones that are multi-layers, right? So you need the 2 to 3 layer surgical masks for that. And then the cloth masks are quite a bit below the surgical masks, and it's all relative to whether they're tightly fitted, whether they have what's called a random type of filtration system or clothing, and then that there are multiple layers. And then, yeah, my comment about the gaiters, yeah, they're only 10% effective, and actually they may be super spreader devices. So I always get a little nervous when I see people running around with those gaiters. Okay, next slide, please. So the reusability, the current recommendations, as I understand them, is that the N95ers should be used up to 8 times with on and off effects, and they're to be discarded. There is some evidence that if you expose them to low heat for a long period of time, that's one way to sterilize them. And so that's, you can actually look that up on the internet. The 3M, the founder of the N95, discovered that. And then by comparison, the cloth masks can be either just hot washed or bleached with soaked in bleach. So those are the solutions there for reusability. Next slide, please. And I think we all know this, but I could tell you just about 100% of my patients coming into clinic are wearing the mask in these different versions. I think part of it, I'm going to do a study just to see if all the patients that come into my clinic who can't wear a mask properly, whether they have cognitive impairment or not, because I think there's a high linkage, quite honestly, for inability to wear the mask properly and memory disorders. But that's a study for another time here. Just as a reminder that pushing the masks up on the face, wearing it under the chin, whatever direction you go in is not proper use of the mask. Next slide, please. So I think this is a critical point, and this is something that would be useful in staff education, is to do hand hygiene before donning on the mask. Usually what I do is I do a spritz of alcohol, and then we'll put the mask on. And importantly, that the mask is handled by the ear loops rather than by the mask itself. Next slide, please. So some of the issues that come up with PPE, and I think these are fairly familiar, is that people can have a sensation of overheating. Certainly you get sweaty hands from gloves, and as a consequence, you might get people predisposed to dehydration from wearing a gown and not drinking enough fluids, during the day as they're fully gowned and they've got their masks on, working in the COVID unit or whatever. There could also be mechanical skin damage, such as acne mechanica. I actually get that myself when I wear my N95 masks. At my old age, getting acne has been quite a revelation here. But I wish it would make me feel like a teenager again, but it doesn't. But the point is that some of the mitigating ways to deal with the skin perturbations is to make sure you have a good moisturizer, is the recommendation from dermatologists. And so that's the point. And then also try to avoid readjusting, the face mask. I always find myself kind of fiddling around with it, and you're not supposed to touch it, and I catch myself doing that. So yeah, there's just a lot of things that go on that we do almost unconsciously, subconsciously, or whatever. Good. Next slide, please. So
The study that we're going to cover today basically walks us through a COVID PIP from the point of identifying an issue to forming a team, conducting root cause analysis, implementing interventions, and evaluating its success. And soon we'll see it come up on our screen here so you can follow along with me. Next slide, please. Okay, so the issue at hand in our case study today is just this. During the daily QAPI committee huddle, staff identified that there were 5 new COVID cases on Wing 1. So before we move to the next slide, I'll just pose a question for everybody out there, and you can respond in chat if you have an answer. So what team members do you feel could provide the most insight into this issue? We have a string of cases that were identified on a particular wing. Who do you think would be beneficial in providing some insight into that? CNA and nurses. And Monica says floor staff. Absolutely, frontline staff are have particularly good insight into these things. Staff that are doing hands-on care. Yep, floor staff. Good. Well, let's move to the next slide. So in our case, the assistant director of nursing and the CNA champion on the QAPI committee provided quite a little bit of insight into this situation. The Wing 1 assistant director of nursing indicated that all staff appear to be donning and doffing PPE appropriately and wearing masks per protocol, but the new staff on her unit have required additional one-on-one education regarding necessity of proper hand hygiene following each resident care episode. And the CNA champion on the QAPI committee shared with the team that in previous employment, their training protocols included return demonstrations, and this is not currently a part of the training program in their facility. So, Dr. Jurevich, can you tell the group how improper hand hygiene can contribute to the spread of COVID?
Yes, certainly. So the recommendation is 21 seconds of hand scrubbing. I don't know where they got that extra second in there, but in any event, hand contamination, not just with COVID, but also with C. difficile spores. So all these recommendations that are made for the donning and doffing and preparation for the donning of the gear are based upon just general infectious disease protocols. And so that's important. And I think one of the points that has been made, and actually somebody, one of the facilities that reportedly got a citation, was that the surveyor observed one of the staff members not wetting hands first before applying, soap. And so that's just one of the techniques to make sure that there's proper hand washing techniques. But yeah, that's so important to do hand hygiene before you either touch something. So for example, if I accidentally touch my mask or my clothing, I'll go and do hand hygiene again. Same thing also with handling equipment, like in the clinic. If I use, let's say, an otoscope or something to that effect, and I'll even respritz my gloves with alcohol before I work with the patient. So, did you want to add anything to that, Jean?
Well, I know in the past we've talked a little bit about the repetitiveness of hand hygiene and what's known as repetitive fatigue. And so then it's tempting to take shortcuts in those cases, and we really want to urge staff not to do that. All staff should be fully informed of the proper process involved in hand hygiene.
Yeah, and then I would just add to that, and just in our conversation here, one of the recommendations for facilities to have a buddy system so that one can remind the other about that. And I find that even with in my clinic, I mean, we don't particularly have a true buddy system, but we are matched up with providers in our offices. And so sometimes just by your own actions, those can be helpful for, reminders. So when I come in, each time I come into my office booth, I'll spritz my hands with alcohol rub. And that's just, again, a demonstration that is reflected by my office suite mate, who then ends up doing the same thing, who may not, quite honestly, consistently do that when I'm not there. So anyways, okay,
And
sorry,
another-
Jean. Yeah.
Oh, another strategy that's been proven highly effective in promoting proper hand hygiene are observations with real-time feedback. You know, so if you see someone taking a shortcut, to feel comfortable enough to approach them, you know, using a buddy type system, and asking them to do it according to the guidelines, or reminding them to do it according to the guidelines.
Yeah, that's a good point. And then, Jean, could I just ask your opinion? So these case reports we get from the national collaboration. So these are kind of considered national standards or ideas. And you know, in the scenario, they were talking about a daily huddle for QAPI, you know, for the QAPI team. What's your impression? Is this something that we're doing routinely with our facilities and the Dakotas, or any reflection on that concept?
You know, I'm probably not the person to answer that. Michelle, do you have any insight on that?
I think it'd be great to hear from the participants, whether they're doing a QAPI huddle. I do know that a lot of places do daily huddles, where they bring, especially during this COVID, where they bring their nursing staff and maybe the medical director and that leadership staff together quickly to get updates on what's going on. But I don't know if the QI portion is included in that. And I think that would be a great asset to those huddles. How about those participants on our call today? Are you doing daily huddles, and are you including QI in part of that?
Yeah, so if you can just put in the chat section whether you're doing that, or if not, whether that's an idea that you can think about.
Here's some from Megan. We have daily huddles every day, twice a day. Awesome. And slight talk related to QI. That's great. Thanks, Megan.
Okay, well, feel free to continue chatting in your responses to that. I'm going to go ahead and move on to the second item that was unearthed, and this by the CNA champion, who indicated that return demonstrations weren't a part of their current training program. Just as another, I would like you to also chat into the chat feature of our venue today, whether or not you feel that formal orientation has been difficult to maintain during COVID. Have you ran into these issues in your facility too? Seeing more come in on the daily huddles. All right. Well, going back to our case study, the committee decided to launch a performance improvement plan, or a PIP, to address proper hand hygiene that was based on these issues that were unearthed, in order to decrease the spread of COVID and other infections in their facility. So next slide, please. So the first step that they took was to put together a team. The QAPI committee created a team led by a QAPI champion CNA, and it included a CNA from Wing 1, a charge nurse from Wing 1, a staff trainer, the assistant director of nursing, and a dietary aide. Michelle, would you tell the group why it's so important to include multiple disciplines in PIP teams and QAPI committees?
Sure. It's essential, of course, especially, depending on what your topic is, to have some of those subject matter experts as part of that, so that nursing staff, as well as those hands-on staff that are actually doing the work, the CNAs, dietary staff, depending on what our topic is. But I also love the idea and think it is crucial to have other maybe more non-traditional disciplines added in there too. It's amazing what, those of us in clinical practice get so used to what the protocol is. And sometimes we do get that fatigue and forget things. When you bring in staff from other disciplines, they are very often aware of things that we might miss, and things that we have gotten so used to seeing that they might catch something or have an idea of a intervention that we haven't ever thought of, but they're coming at it from a different venue. I have lots of great experience with housekeepers knowing before the nursing staff of when a resident is not feeling well. Mrs. Jones hasn't talked as much today as she usually does. I have way back experience in an ICU setting where we couldn't figure out what was going on with our resident whose blood pressure was or our patient whose blood pressure out of control, swelling. The housekeeping staff was cleaning the garbage every day and knew that somebody was bringing saltines into the patient. Nobody else knew that. And that was wonderful information that we would have never gotten if the housekeeper hadn't been part of the team and shared that. So.
What a great example. Thank you. So next slide, please. Whoops. There we go. So the team reviewed the issue and completed a root cause analysis to determine underlying issues. And they discovered that the new employees are unfamiliar with the policies for their facility, that CNAs are assigned to work on units solo after just one day of shadowing. They also discovered that training for new hires consisted of a read and sign in service, and there was no formal orientation for CNAs. And there was also an increased turnover related to COVID, which resulted in shifting priorities from orientation to staffing and floor. And I think that most facilities can attest to that situation recently. So if you wouldn't mind chatting in again, is there a particular root cause analysis that you find more helpful than not when you're conducting your PIPs? For instance, do you use fishbone diagrams? Do you use the 5 whys, the who, what, when, where, and how? You can just type it into chat, please.
Yeah, I was going to mention, Jean, that from my perspective, I absolutely love the fishbone diagram because it reminds me of all the walleye that I never catch.
Good point. Regarding the fishbone diagram, IHI has a very nice document available to do this, a template to do it, as well as instructions for it. I know we recently had it, we recently had a link to that. We should find that and post that today if we can. So I see somebody says they're using the 5 whys. That's great. Megan says, initially we did, however, we're now using a return demonstration with staff and have gained valuable insight onto what the staff have knowledge of. That's great. Staff interviews are a great way of finding information and understanding the root cause. So Michelle, thank you for posting the cause and effect diagram that I just referenced. And Jessica Matson says they're using stop and watch. I'm not familiar with that.
That is part of the Interact protocols,
Okay.
which are wonderful. That's great tools, and that really brings in your frontline staff. It's a tool for them to help capture what's going on with residents, changes.
Perfect. Perfect.
Yeah, and I was just going to mention, Jean, that kind of stop and watch approach is something that can be done by a staff member who is assigned to that. So one of the things to further engage the CNAs, for example, in QAPI efforts are to have them perform the stop and watch. Another technique that we'll talk about is partnering the CNA with the nurse at bedside rounds. So this is another technique, for identifying information. Also in the root cause analysis, it's valuable to get information from the residents as well as from the staff, as well as from leadership. So, as we go through this, so just to give you an example, this not related to infection control per se, but in the nursing home, when I would do rounds, I always check if the individual is more or less bedbound or was wearing Depends, and I knew that the family members were complaining that the staff weren't changing, the Depends frequently enough that they, and so the question was whether that was true or not. And the only way that I could determine that as to whether the Depends were fully soaked or oversaturated. So that to me was an indicator that they weren't keeping up, with the changes. However, if they were moist, but still dry at the skin level, we would go back with the family member and just explain to them that the point is that those devices, those diapers, are supposed to be absorbent, and so that they wick the fluid away from the individual. And so what we did is we charged the family member to identify moments when the Depends were super saturated, and so we educated them on that. So that's the kind of feedback that we got back and forth from both staff and the family members, for example.
Very good points.
So back to you, Jean. Yeah.
Okay, thank you. All right, well, we'll go on to the next slide. So now that the team has identified the underlying issues, they put some interventions into place. And those interventions included that the team identified all new hires within the last 6 months. So in this case, it was since COVID, and conducted one-on-one training on hand hygiene with return demonstration. And to kick that up a notch, the team also developed a schedule to conduct one-on-one training with all staff on hand hygiene with return demonstration within 3 months. They then created a list of standard trainings to be completed by all staff. And of course, that included training for hand hygiene with return demonstration. And finally, they created monitoring measures to ensure that the effectiveness of their hand hygiene training. And through this data that they collected, or in their process, they observed 10% of staff performing hand hygiene each month. Their baseline started out at 68% prior to training, and by the end of monitoring, which was their 6-month period, appropriate hand hygiene was up to 100%. They also reviewed active COVID diagnosis for 3 months. On baseline, it was 3.9%, and by the end of the monitoring period, it was 0.6%. So in this case study, you see that their interventions were highly successful. My question to you all is, does the ball stop here? And I know you don't need to chat in that answer. We all know that the answer is no, that even once you've achieved your goals, you should continue to monitor, perhaps less frequently, but always assure that your gains have been sustained or are being sustained moving forward. And then, of course, moving forward, you want to consider maybe replicating this PIP and applying it to other issues that have come up in your facility. And in the process, utilize lessons learned and best practices that can be incorporated into that PIP. So if there's any questions or feedback, I'd be glad to field that now.
I would just add, Jean, that the observation that 10% of the staff are observed each month with hand hygiene reinforces the ideas that the PIPs really involve relatively small numbers of people. I think one of the biggest concerns about quality improvement is just the time that it takes to follow up and to get the data. So one of my hand hygiene projects that I deputized. Yeah, I actually had a little sheriff's badge that I gave to a housekeeper in the teaching nursing home that I worked on. And I said, I gave her a notebook, and I said, I want you to just mark down, staff, as they're to see if they're spritzing their hands as they come out of the room with alcohol. And so, she created this list, and we discovered that we were about 50-50, right, on doing that. So it was like I said, one of those undercover operations there. And one of the lessons I learned from that was that the housekeeping then sort of became the devil's incarnate, with the CNA and nursing staff. They always looked at them kind of suspiciously, like, are you watching me or whatever. So it was not so good for team building, as the lesson I learned. So we went back and had to kind of reconcile the whole situation with my favorite was giving food cards or a Starbucks card. So the egreged staff on the wing that we're dealing with all, as they improve their hand hygiene over the next month, going to, over 90% compliance, they all got small token Starbucks gift cards. So, and I know that Starbucks is not in every town and city that we're dealing with here in North Dakota, but there are other opportunities for rewarding people in that way.
Absolutely. Absolutely. Well, are we ready to go into this chat, or do we want to go back to the video that Dr. Jurevich was going to show?
Yeah, I think that video is going to take us over time here, and we'll leave that up to our participants to access the video at a later time. So if they go to our website, and they'll see this presentation, and if they can look at that video, that would be wonderful. But yeah, why don't we just kind of, we're getting close to the hour here, just go on to our next questions.
Okay, well, today and moving forward in this collaborative, I want you to continually ask yourself these questions, but for today, I would like you to type your answers into chat if you could. What is going well in terms of QI around infection control? For instance, donning and doffing PPE, hand hygiene, etc. And if you can identify what's been challenging or an area where this particular community, Echo Can community, could help you out, we'd be interested in knowing that. Laura says hand washing, UTIs and wounds. Good. And Megan says daily audits have been helpful to identify weak areas. Megan, do you have your own internally developed audit tools, or do you have a template that you use that's been provided? Both. Okay, good.
Yeah, I was going to say that's always good. Yeah, so one of the goals for us is that if you do not have a tool for doing those kinds of audits, that we can certainly pass those on. And I think the important point that's made here is that the tools that are available can be adapted to your own facility needs. And sometimes the tools are a little too lengthy, so if they've got like five or six checkpoints, you can reduce those down to 1 or 2 checkpoints just to audit and monitor your performance.
Great. Jennifer Mitchell from Trinity says they're doing ongoing or they're doing weekly rounding on all PPE, hand hygiene, etc. And they do about 100 observations a week. Jennifer, you're from a larger facility. How long does it take you to turn that data around and address any deficiencies or any weaknesses that you see? That's a lot of data.
Yeah, I really am sensitive to that idea of the pool staff following protocols and so forth. So, you know, part of that is, at least in the nursing literature, the idea is that you're supposed to do one-on-one training, followed by a group training, and then followed by one-on-one training as being the optimal method, you know, for training. But I think that teach back is always important in creating that time, you know, for doing that. And then also, you know, for that, you might go back and do an audit of the pool staff. Just, you know, have, again, somebody do a buddy system that you hook up the pool staff with a buddy, and the buddy goes back and just, you know, does an observation.
Very good. All right. Well, do we want to keep going with this, or shall we?
Yeah, I think we can kind of move on, and then we can do the summary, and then we'll leave it open for 10 or 15 minutes afterwards for those that want to stay on and just share their the ideas about how they're doing their audits and so forth. So to summarize our ECHO session today on PPE, next slide, please. Just want to kind of go over some of the basic principles focused on masks, and this is information that Faye Salzer, our North Dakota State Department of Health consultant, provided us with today, and I'll show you the resource for this. But just to reinforce this concept as leadership, as we're looking towards our staff and our visitors, quite honestly, and I think there's a tremendous opportunity to work with our visitors as they're coming in to get proper education on mask use. I can tell you my experience at a Toyota dealership was a mixed one in terms of, you know, kind of looking at their use of masks. And yeah, I've already made my comment about the Gator masks, and so, you know, there was about 10% of the staff walking around with Gator masks, and you know, the other group had the cloth masks sort of half off their nose, and when they were talking, the mask you know, flipped off the nose. And actually, the salesman that I was working with had that problem, and I kept stepping back further and further from him, and he started kind of taking a sniff of his shirt. He thought maybe he had some other issue going on, and you know, it was just my fear that you know, he was not wearing the mask properly. So the important point there from that story is that the snug fit around nose and face, there's a thing called Venturi effect that occurs with the airflow that comes out the side of the mask. So you don't want to be standing behind somebody when they're talking, because that's where all the jet air is spewing backwards on the individual. So face-to-face encounters are actually encouraged. And the mask needs to cover both the bridge of the nose and ideally should be under the chin. And that the loops, the ear loops, can be attached by a styrofoam or plastic device behind the neck if somebody gets a little irritation behind the ears, or it's just not comfortable for them. And importantly, there have been some masks that have had vents, and those are not recommended by CDC. Next slide, please. So the problem with the masks, cloth masks alone, is that they generally are poorly fitting, although they have adopted or adapted some additional ones that are a little bit better fitting. And the point being is that those gaps around the nose and cheek can allow respiratory droplets to leak out and get into the you know, the air. And again, that's called Venturi effect. Next slide, please. So the surgical masks are preferred. They have a higher efficiency. They're about 60% better than cloth masks. They need to be multi-layered. And an important point just to stress is to use those masks to put them on by the ear loops and not by touching the surface itself, if at all possible. And also the other recommendation is to make sure that you do hand hygiene before putting the mask on. Next slide, please. So one of the problems with surgical masks is that they sometimes do fit loosely. and they don't always have those ear loop adjustments, although there are some that are coming out now, and they actually have those little beads. I don't know why folks, the entrepreneurials haven't addressed sort of designer beads to put on those things. That could be, if anybody's interested, give you a business idea there. But the point being is that the poor fits do cause gaps, and that fit and efficiency of the surgical mask can be improved by overlaying it with a cloth mask, and so that actually produces 92% particle reduction by that double masking that came out from the CDC here just in the last couple of months or so. And so double masking is considered preferable to single. The one caveat is don't use 2 surgical masks. This has to be the paper disposable surgical mask, and then overlaid with the cloth mask. Next slide, please. The N95ers, so the big deal is that the KN95ers, 60% of them are not working too good. So it's a real disappointment. And there's a lot of fake KN masks on the market right now. They're supposed to have the NIOSH, the NIOSH symbol or mark on the package to be authentic. The recommendation is that if you're going through N95ers a lot and don't have a backup supply, that you go through 8 uses as on and off donning, as opposed to like 8 days. So if you use the mask 8 times on and off, that's the lifespan of that particular mask. For those that folks of my gender that have beards, masks don't work so good. So that's always a consideration, for meeting the pandemic, as to shaving the beards. And then just to point out that even with the N95ers, when you do a fit test, that there is a 15% failure rate, and that's actually improved with refitting by another 8%. So you're still going to have like that 5 to 7% of N95 masks that may be difficult to get a complete fit on them, just to be aware of that. Next slide, please. So as mentioned with the N95 masks, some of the issues are they can be a little bit uncomfortable. So you get more fatigued, with the wear of them. There may be the sensation of breathing issues. I'll just mention that there was a study that showed elite athletes who are like, distance runners, so they're breathing very hard, and that the masks did not impede their oxygen intake nor their CO2 exhalation. So basically, if an elite athlete can, get enough oxygen and breathe out the air, that there really is no issue with that. Whether the person has, breathing difficulties like asthma or so forth. It's more of a sensation of heat under the mask that makes people feel that they're kind of, I don't know, not suffocating, but just feeling impaired breathing. And then the other point that I've already made is the counterfeit masks that are circulating right now. Next slide, please. One of the ideas that have come up is to try to improve the mask fit. So I'm not sure if anybody's using these flexible braces, but that can fit over the surgical mask. So that's one option for improving the efficiency of these particular type of disposable masks. I think this is a really good solution, quite honestly. Next slide. We've already mentioned about alcohol sanitizing as you go back and forth with the mask. The wire over the nose is good for preventing fogging of glasses. So that's always important. And again, if you do that adjustment, you do alcohol sanitizing of your hands before you touch the mask. Next slide, please. And improving the fit is important because, as you can see here, that's what I'm calling Venturi effect, where small spaces tend to create the particles going outward. So most of the studies on masks show that the particulate matter goes retrograde or behind the neck. So that's key, in terms of just even positioning people. Like, so if you have a group huddle or something like that, you want to get everybody kind of more, socially distanced as best possible, but not have people stand behind one another. So that's just a small technique, for consideration as you try to reduce the exposure to particulate matter. It's all relative risk, quite honestly. It's not, none of this is 100%. And so it's just every little bit really can make a difference. Next slide, please. So improving the fit, like I say, the addition of these little beads that you can, tie up and pull the mask tighter, or you can actually do a tuck, and fold technique there is shown. So that's another technique if you see one of your staff members with, a little looser fit than what you would like. Next slide, please. You can do a self-check, so cupping your hands around the top and side of the mask to detect airflow. And really the one that I use most is just whether the surgical mask is moving back and forth with the cloth mask in combination. So when people talk, it should give a little puff of a dome puff on that mask. Or when you see them breathe, the mask should kind of suck into the sides of the nostrils, as an example. Next slide, please. Then, really importantly, to continue staff education, again, the emphasis on wearing the mask and the social distancing. I always talk about bringing my walking sticks. When I go hiking, it's got about a 6-foot span, and I feel like I brought it into clinic once and it wasn't too popular. So but the idea is that, to kind of keep that social distance as best possible. Obviously, in dealing with resident care, you're next to the patient. So it's, as you can, do the social distancing. But then again, wearing the mask with a tight fit is important, and educating the staff on that. Next slide, please. So just as a thought, again, we're hoping that there's a PIP of the month club. So if you reflect and look and whether you've initiated a PIP over 2021, just to consider maybe each month to do a new PIP. These should be ongoing. And so one suggestion was just to do observation of a staff member putting on an N95 mask with the loops as opposed to touching the mask. So that might be just a very, very simple observational masking audit. Next slide, please. Oh, yeah. I just wanted to mention a little bit about mask innovations. These really fascinate me. So people are using 3D printers to create masks. I haven't gotten my hands on any of these. But the MIT program created a clear rubber mask where you can sterilize the mask by autoclave, and they have replaceable filters. UC Berkeley, again, has a different material. It's a silicone mask that comes with, in both cases, these have replaceable filters. Next slide, please. And Ford Motor Company, in addition to, I guess, producing a electric Mustang coming up here, they've also produced a clear mask, which would probably be good to use on the dementia units, quite honestly, so that people can better see your face. So I really think that this might be the clear plastic mask may be a good thing here down the pike. And then Honeywell also has an N95 mask, which actually is a little bit more effective than the 3M mask. And it's got replaceable filters in that. Good. I think is there one more slide? Yeah. So these are the CDC resources for the masks. So all those pictures that I put on were from this guide.